Hello and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, Professor Emeritus of Pediatrics at the University of Arizona College of Medicine, and Medical Director of Infectious Diseases and Immunizations at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic. This is the week of December 6th, and as we all know, there's a new variant on the scene, the Omicron variant. Case numbers are unfortunately increasing, yet still in Arizona and other parts of the country, and our numbers are going exactly in the wrong direction. Globally, we are now up to 267.3 million total cases, with 5,275,023 deaths in the world. For the United States, we are at 49.4 million total cases since the start of the pandemic, and 791,514 deaths due to COVID-19. In kids, the most recent report from the AAP from December 2nd, we are just over 7 million total cases, which is 17.1% of the total cumulative caseload. That comes out to 9,344 per 100,000 pediatric patient. And again, perhaps the more telling number is the weekly percentage of cumulative total. If you recall, with the Delta variant and this current surge, children have been accounting for over 20% of the total caseload and as high as 30% at one point. The last week, children accounted for 22.4% of the total cumulative caseload reported for that week. Here in Arizona, we are at 251,061 total COVID-19 cases in pediatric patients. That is 19.7% of the total cumulative load, and 13,655 cases per 100,000 pediatric patient. So again, numbers are unfortunately still going up. We'll talk a little bit later about COVID-19 related deaths. Arizona up until recently had been at 49. We are now at 50, and remain second only to Texas with cumulative COVID-associated deaths in pediatric patients. So some great questions again this week. Thank you all for sending them. We'll just start top to bottom. So can I provide a simple 1 or 2 sentence explanation of monoclonal antibody treatments to help us explain that intervention to parents? And how can we easily explain it? I think probably an analogy is the easiest way to explain immunology because it's fairly complex. For us as scientists and healthcare providers, the monoclonal antibody is a specific fragment of antibody which is designed, or many times cleaved and produced, to accurately and specifically bind to an active binding site. So rather than a global antibody which has sort of a more generic binding site, for example, specific to the COVID-19 and SARS coronavirus 2, all the antibodies we've been using or trying to create have been dealing with various parts of the spike protein. Spike protein for the coronavirus is the structure, the protein structure responsible for binding of the virus to its target epithelial and endothelial cells, and it binds to the ACE2 receptor. Now, within the spike protein, there are multiple antigenic sites, meaning recognition sites that the human immune system could recognize and respond to. However, only a very few of those are specifically involved in the specific binding to the ACE2 receptor. So to create a general, antibody to the whole spike protein would be very large and huge potential for crossover reaction, lots of autoimmune reactions. It'd be a very dirty, messy intervention to use. And that is in part what we experienced with a hyperimmune globulin from COVID-19 survivors. They had a vast array of antibodies created to various points of the SARS coronavirus 2 spike protein, which were largely ineffective because they were just too broad. Instead, the monoclonal antibodies target specific structures of the spike protein binding site. So exactly what you want to fill in and prevent from binding to the ACE2 receptor. So that's the science part. How to explain that to parents? You could use any sort of analogy. I guess one is, I've got a hole to fill in the driveway out front. The general antibody response would be to bring in a dump truck full of sand and coat the entire driveway. Yeah, it'll cover up that hole so you can't step into it and break your foot, but it's going to cover a whole bunch of other things too, which you may not want it to be covered. versus the monoclonal antibody approach, which is a specific patch of pavement into that hole so you don't step into it and break your foot, but it doesn't affect anywhere else in the driveway. So it's really about specificity of binding and still conducting its effect. So feel free to use that, or if you're smarter than I am, use another analogy, whatever works, whatever might help your parents or your kids comprehend the concept. But have fun, go for it. Okay, next question. What do we know about the new variant, the Omicron variant? Is it more transmissible? How does it affect children? So keep in mind that this is just several weeks into the new awareness of the Omicron variant. So what I'm saying now very likely will be more specific or new or different even a week from now. But what we know as of today, when I'm recording this early December, is that the Omicron variant emerged and was identified by a laboratory in South Africa. Whether it started in neighboring Botswana or South Africa remains to be determined. The suggestion is that it may have emerged in a single patient living with or undertreated HIV/AIDS in South Africa who had chronic infection with SARS-CoV-2, and a mixing event seems to have occurred. What does that mean? Just like influenza with antigenic shift, where it acquires genetic material from another influenza, creating a whole new virus or a significantly genetically different virus, that seems to have occurred in this case. So Omicron variant is thought currently to be SARS-CoV-2, whatever was circulating, probably even a half year or a year ago, that acquired genetic material from another coronavirus, which may be the OC43. That other coronavirus is the cause, or one of the causes, of the common cold. So just like rhinovirus, and in fact, you may get respiratory panels that give you rhino/enterovirus. It's the enterovirus component of that detection causing the common cold, which seems to have shared some genetic material with a largely historic isolate or variant of SARS-CoV-2, creating the Omicron variant. What that means then is that Omicron has 50 new specific mutations, 30 of which are in the spike protein, again, that component of the virus responsible for binding, and 10 of those 30 spike protein mutations are specifically in the binding site responsible for its binding. So that means that it does appear to bind more successfully and be transmitted more readily, in part because it now has properties of the common cold plus COVID-19, plus SARS-CoV-2. But the early suggestions are that it is less virulent. So people in general, both adults and pediatric patients who are infected with Omicron are having the fatigue, the respiratory, the congestion, but not necessarily the dyspnea, the shortness of breath, the respiratory failure, or the multi-organ failure. They're sick kind of like a bad common cold. Sorry guys, but like a man cold. But they're not sick as long, and they're recovering much more successfully. And again, early so far in this new variant, there's no early indicators that it's any more deadly, in fact, maybe even less so than Delta variant and the preceding Alpha and Beta. So that's what we know in general. Yes, it has definitely been demonstrated here in the United States. As of last count, 13 states in the U.S. I'm sure that number will increase to 50 and in just the next week or so as people continue to travel. It has affected at least 28 other countries in the world, all travel associated, and now with local spread with many clusters in those countries. Kids do seem to be at risk for Omicron variant. They do seem to have similar mild disease to what I just described. And in fact, some of the earliest clinical descriptions we have anecdotally from physicians in South Africa were in pediatric patients who actually came in with bad headaches and then happened to have been found to have, COVID-19. So yes, kids are at risk for this. This sort of gets into another question, which is, what about current vaccines? What about current interventions? Are they still going to be successful with Omicron? And again, super early to tell, but an early indication with research just released on the airwaves from Pfizer is that the Pfizer vaccine still appears to provide protection against the Omicron variant. Clearly, this is just a couple days old, so we have a long ways to go to confirm that. But it appears that the vaccines currently available in the United States, and specifically the mRNA vaccines, Pfizer and Moderna, are going to be, and currently are, protective to a large extent against Omicron variant, especially in patients who have had the booster dose. This is in direct reference to one other interesting phenomena of Omicron, in that it appears to very readily, and perhaps even more readily than others, cause reinfection in people who have only natural immunity. So those individuals who have had COVID-19 and have not been vaccinated, or who have not yet received their booster doses, appear to have a higher rate of reinfection with Omicron. Again, this may be that component of a alternate enterovirus sharing its genetic material and just making it more infectious and easily able to bind to respiratory epithelium. So that, I think, is a huge call for vaccinating every single person we possibly can and boosting everybody in the country ASAP, as I'm sure you all have seen, coming out of Washington, D.C. and the CDC. There's a strong call for everyone now who can be boosted to get boosted. Just as a update, I think we all saw this, but just in case you didn't, the boosters from both Moderna and Pfizer are now approved, recommended, etc. by the CDC and the FDA for everyone in the country who's age 18 and up. And for the Pfizer booster, it can be age 12 and up. So go for it. There's no longer any limitation in terms of high-risk exposure, healthcare worker, older age, etc. Everyone gets a booster who's able to get a shot. That, I think, is going to be the best way to approach and navigate the potential impact of Omicron. So, given that next question, given that transmission rates are continuing at a high rate, what mitigation practices should be practiced at this point? Boy, mask use, of course, is the simple, harmless, easy to administer thing to do, and masks remain effective. There's no magic about the type of mask. Again, the surgical loop or tie-on masks and the fabric or paper involved with those remain effective at limiting droplet transmission by the wearer, and they remain about 60 to 70% effective in preventing inhalation of droplets by the wearer from somebody else who may be contagious. So absolutely continuing with masks, mask mandates. Yeah, we would love to get away from mandating this and mandating that, but they work. And there's continued evidence from school systems, from closed office spaces, from you name it, that mask mandates do work and reduce secondary transmission within a enclosed community, a classroom, etc., and so forth. So first and foremost, continuing to support masks, mask wearing at all of our clinical practices, certainly through the AAP, and that's messaging which I think you can find quite readily on the AAP's website, and of course the Arizona chapter AAP's website. But then also continuing to support and promote vaccines for anybody and everybody, having those vaccine conversations. Interestingly, the news of the Omicron variant and the fact that vaccines and booster vaccines were successful against it created a 25% increase last week in vaccine uptake across the country, all ages. 25% increase. Now, again, that's the 25% of what was already kind of a lower number, but it's an increase, not a decrease. So I think just in terms of the messaging and even the level of concern in a community, now is a very good time to harness that and to come out strongly in support of vaccinating everybody in the family who legally and should be get the vaccines in, get the boosters in. Next question, given the higher transmissibility of the Delta and Omicron variants, are there any types of masks that are more effective than others that can be used? Well, of course, the most effective is going to be the mask that's worn properly. Duh. I think we've all seen the mask below the nose, the mask covering the chin, the mask above the eyebrows. So obviously a mask that's worn covering nose and mouth is going to be more effective than one that's not. That said, the more effective the mask material, such as an N95 mask material, the more successful it will be at limiting both droplet and aerosol transmission. Keeping in mind that SARS coronavirus 2, all variants so far as we know, are able to be transmitted via aerosol transmissions of those tiny, micron particles that can persist airborne for more than just, a couple minutes and for longer than the 3 or 6 meters that we've all been told about. So to be absolutely 100% effective is impossible, but close to that would be wearing an N95 mask. I would suggest, and I think we could suggest this to our families, that wearing the N95 in a high-risk exposure, such as air travel, such as any sort of public transportation, a very small closed space where one will be within 3 feet or 6 feet of other people, the N95 mask is a reasonable option. Certainly, I wear one if and when I fly. But for all others, the regular surgical loop mask remains very effective, especially if everyone is wearing it. The key, of course, is to just sort of prevent the droplet transmission from the source, as well as providing some secondary benefit to those who are wearing it. Okay, next question. Given that children are just now getting vaccinated and many adults are getting the booster, what is the likelihood of the need for a new vaccine to combat new variants? Might another booster be necessary? Well, to sort of extend on what I talked about just a little bit ago, the current vaccines available, so again, Pfizer, Moderna, I'll get to J&J, the Johnson & Johnson in just a second, but the mRNA vaccines appear to have efficacy and therefore ongoing utility against even the Omicron variant of the virus. And it is suggested, but not yet proven, because just haven't been doing this long enough, that the booster of either mRNA vaccine will provide long-lasting, successful protection, potentially excluding the need to do annual booster shots going forward. Could a new variant come through which completely escapes immune protection? Yes, of course. And if so, then the mRNA vaccines can very readily be retooled to provide protection against that variant. That would mean revaccinating the entire world population, of course, but scientifically it's possible, and it's possible within a very short period of time. As we speak, Pfizer and Moderna are tooling their vaccines, if needs be, to respond directly to the Omicron variant and its new mutations. But at least so far, it does not appear necessary to do an Omicron-specific booster. So the hope is, and the early indications are, that getting the booster now will prevent the need or avoid the need to have subsequent boosters in the future. Fingers crossed. Obviously, a lot can change, and as has been said by many people, both scientifically and publicly, 5 years from now, we'll know all the answers. Yeah, of course, that's totally true. Right now, the indication is, as I just said, that we should be okay with booster dosing. Now, what about the Johnson & Johnson vaccine? Keeping in mind that this was created and then tested in the early days of Delta variant, so its efficacy numbers were lower than initially reported for the mRNA vaccines. However, not a fair comparison because, of course, it was tested against a more difficult to protect against a variant, the Delta variant. That said, its ongoing protection against current variants, the Delta and even the Omicron, is not as high as are the mRNA vaccines. And so the current recommendations are for an individual who received a dose of Johnson & Johnson vaccine, and this, of course, is going to be largely not our patient population because it's approved age 18 and up. But for those parents, for example, or ourselves who got a J&J vaccine, getting a booster, or I guess a second dose, with an mRNA vaccine is highly, strongly suggested. Those individuals who get that, so a J&J vaccine followed by a Moderna booster, have a 47-fold increase in their immunoprotection, that's monster immunity. Even a J&J vaccine followed by the Pfizer vaccine has a 25-fold higher increase in immunoprotection compared to a second dose of the J&J vaccine, as they suggest, which is a 4-fold increase. So, I'm not a betting person, but I kind of think which one I would choose. So if at all possible to get the Moderna booster after a J&J vaccine, that would be highly protective. So, yet to be determined, certainly in terms of pediatric indications, the Pfizer remains approved for age 5 and up. Moderna has submitted its data to the FDA for emergency use authorization of that age group, and ongoing studies continue to be looking at ages younger than 5 years for indications there. Again, to be determined about efficacy, safety. Although not asked, I will mention that continued assessment of safety of the Pfizer vaccine for ages 5 and up continues to demonstrate a good safety profile. There have been anecdotal reports, and this has been previously stated as well, that children, even young adolescents and young adults, do have a transient experience of chest pain, which is not related to myocarditis. And in fact, one of our members has related a personal story of their child who had exactly that experience. Lasting for about a day, responded to ibuprofen, no EKG changes, troponins were not obtained. So that happens. And whether it's a costochondritis or a version of the myalgias, which we know can follow a mRNA vaccine, but just so you know, not all chest pain post-vaccine is post-vaccine myocarditis. How do we differentiate between, a true post-vaccine myocarditis and the non-myocarditis chest pain? Probably just tincture of time. So importantly, none of the post-vaccine myocarditis patients have had serious outcomes. They've all had return of normal function, in days to weeks after their onset. All of them who were hospitalized were in-house for no more than 2 days at most, and all responded to non-steroidal anti-inflammatory therapy, NSAIDs, and especially ibuprofen. So the point being that it is safe to wait, to monitor, to watch expectantly a vaccine recipient who complains of some chest pain, and if it persists for more than 24 hours or keeps returning after use of ibuprofen, that then is a patient who deserves to have an EKG obtained and a troponin level checked, just to clarify or confirm that they may or may not have post-vaccine myocarditis. Again, and I've talked about this before on the podcast, the risks and the rates of myocarditis after actual COVID-19 are logs higher and far more severe. These are patients who have pronounced and prolonged cardiac dysmotility, decreased function, exercise intolerance, the whole 9 yards. So again, night and day difference between risk and severity of myocarditis following the real thing versus vaccine. So again, the data completely supports proceeding with vaccination. Just be advised that some of your vaccine recipients may phone in with a transient complaint of chest pain. Reassurance is the best way to go unless it persists for more than 24 hours. Other vaccine safety issues, again, mild malaise, mild headache, of course the injection site tenderness, but many of the kids age 5 through now 18 are doing quite well post-vaccine with very minimal complaints of side effects and continued activity, etc. So last question has to do both with an article and then also I think the issue of the deaths reported with the Arizona Fatality Database report. The deaths reported due to COVID-19. And I think we may all have seen some of this covered in the media or are aware of the data reported on the report. But 12 of the 49 deaths reported in the report related to COVID-19 were actually due to the virus itself and medical complications of that, meaning children who had progressive disease, multi-organ failure, all due to the virus, and experienced respiratory failure, multi-organ disease, and unfortunately died as those complications. The remaining deaths, the 29 deaths that were initially recorded as associated with COVID-19. Now, the report says COVID-19 caused, but there's a general definition which includes deaths related to other factors which can be related to the pandemic. So those 29 deaths include children who died by neglect, children who died by suicide, children who died through inability to access care because of the pandemic. So the definition basically says, had there not been a pandemic, would that death have occurred? And that's, again, you might say, gosh, that's a loose definition, but it's a way of really recording the devastating impact of the pandemic on adults and certainly on children. And so deaths related to the social impact and healthcare impact of the pandemic do count. But you'll note that discrepancy in terms of actual viral caused deaths and viral associated deaths. Okay. So I think that is it for the questions. As always, thank you for listening to ID Talk. AzAAP members can submit questions for future episodes to covid@azaap.org. AzAAP would like to acknowledge the generous support of this podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to COVID-19 in Arizona, or to learn how to become a member, please visit us at azaap.org. And as always, and in the meantime, hang in there in this holiday season. Keep the hope, keep the faith. It's an ongoing storm, but we're all in this together and we can make it happen. So thank all of you for your service. Be well.